The information contained in the SSI Spotlight series is designed for and intended for use by the NCAA membership. The webinar content represents the views and opinions of the participants and does not necessarily represent the views or opinions of the NCAA. The content has been made available for informational and educational purposes only. The NCAA does not make any representations or warranties with respect to the accuracy of the content, nor is the content intended to be a substitute for professional medical advice or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The webinar is intended for personal viewing only and may not be recorded.
Hello, everyone. My name is Dr. Dina Casiro, NCAA Chief Medical Officer and Senior Vice President of the Sports Science Institute. Welcome, and thank you for joining us for part 3 of our SSI Spotlight on cannabinoids. This session will continue the conversation on the removal of cannabinoids as a banned substance and subsequent shift toward a harm reduction approach for the prevention, identification, and management of problematic cannabis use at the campus level. In our previous session on the work of CSMAS, the chair of the committee, Nadine Mastrolio, talked about the first ever Cannabis and Collegiate Athletics Summit. This summit, commissioned by CSMAS in December of 2022, aimed to better understand the current literature, policy, and research around this topic, and to address cannabinoid use in collegiate sports. And as a result of that summit, 2 sets of statements for consideration were developed. The first set were consensus foundational statements that synthesize current scientific evidence and expert opinions on cannabinoids in collegiate athletics. And the second set were implementation strategy statements for the prevention, identification, and management of problematic cannabis use at the campus level. These statements are meant to serve as a foundational guide for schools to better support student-athlete mental and physical health, safety, and performance. In today's session, we will continue the conversation on outcomes from the summit with a focus on harm reduction implementation with a further emphasis on identification of problematic cannabis use and subsequent referral to care where indicated. At this time, I'm excited to welcome our 2 guests. Dr. Jason Kilmer is an associate professor in psychiatry and behavioral sciences at the University of Washington, and Dr. Tim Fong is a professor of psychiatry, board certified in addiction psychiatry at the Semel Institute for Neuroscience and Human Behavior at UCLA. Thank you both so much for joining us today. Let's start by asking each of you to introduce yourselves and tell us a little bit about your relevant experience as it relates to today's topic. Dr. Kilmer, let's start with you.
Hi, everybody. Yeah, thank you for having me. I'm Jason Kilmer. I actually got promoted in July, so I'm a professor in psychiatry and behavioral sciences at the University of Washington School of Medicine and an adjunct professor in psychology at the University of Washington. And I've been part of a team that for years has been doing research on college student alcohol use, cannabis use, other drug use, but importantly, approaches to how we work with students on those issues. My advisor in grad school was Alan Marlatt, who is the first person on college campuses in the U.S. to start looking at harm reduction, prevention, and intervention approaches. So I've been lucky to be around harm reduction approaches my whole life and part of my whole professional life. And part of my job at the University of Washington involves providing alcohol and other drug prevention content for our student athletes. So thanks for the chance to join you today.
Very impressive. Thank you so much, Dr. Kilmer. Dr. Fong, you're up.
Thank you for having me. Again, my name is Dr. Timothy Fong. I'm a professor of psychiatry at UCLA David Geffen School of Medicine, specializing in addiction psychiatry. I'm also the director of our UCLA Sports Psychiatry Service that combines leading edge mental health treatment practices for our 700 UCLA student athletes. Back in 2017, along with Dr. Ziva Cooper, we also started the UCLA Center for Cannabis and Cannabinoids to try to understand the impact of cannabis and cannabinoids on body, brain, mind, health, and spirit. And so really, this has been now about an 8-year journey now of understanding cannabis and how it impacts student athletes, developing policies that make sense. And really, I think we're so excited about here today is to share with you what we've learned from student athletes, what works, what doesn't work, and to try and remove nearly 80 years, if not more, of stigma and mythology to really focus on the core parts of cannabis, health, and wellness, and not talk about cannabis, punishment, suspensions, and discipline. So that's exactly where we're here for today.
Thank you so much, Dr. Fong. And I really appreciate that segue into our questions here, because really the whole purpose of these SSI spotlights are to help our membership figure out what to do with changing recommendations that come down from the NCAA. So I appreciate that segue. So Jason, my first question is for you. We're here today to talk about harm reduction strategies as a component of substance misuse prevention. Can you define harm reduction for our audience and maybe touch on its utility as an approach to prevent, identify, and manage problematic cannabis use?
Love that question. I think there are some misunderstandings of harm reduction, and people say I get nervous about doing anything related to harm reduction because doesn't it send, in quotes, a mixed message? A harm reduction approach is not anti-abstinence, and it does not equal moderation. In fact, if someone says, I want to avoid all of a substance's unwanted outcomes or harms, abstinence is the best way to do that. But what a harm reduction approach acknowledges is that any steps towards reduced risk are steps in the right direction. For sometimes that means reducing use. Sometimes it's not even use reduction, it's using more protective behavioral strategies. With the example we always give with alcohol is if you're meeting with someone who's a pretty small human being, they say that they always drink 5 drinks every Friday, 5 drinks every Saturday. All 5 of those drinks are shots of hard alcohol on an empty stomach over 2 minutes. They admit they get to a pretty high blood alcohol level pretty quickly, say things they often wouldn't say or do and regret that, don't love how they feel the next day, and are embarrassed to admit that they drive at least once a month when they probably shouldn't. Now they go through a harm reduction focused approach and they decide, I'm done with shots. I'm going to drink beer. I'm done with empty stomach. I'm going to eat prior to and while drinking. I'm done with 2 minutes. I'm going to stretch my drinking out over 3 hours, alternate every drink with water. I've told all my friends what I'm doing. I've downloaded every rideshare app known to humanity, and I will never drive impaired again. What's that? How much am I going to drink? 5 on Friday, 5 on Saturday. If we look at their survey, it looks like nothing changed. Their quantity is the same. Their frequency is the same. But they're getting to a lower blood alcohol level, experiencing fewer consequences. It's successful harm reduction. I think what's important on college campuses, though, is, again, we're not just looking the other way. I'm in a state that is approaching 12 years of legal cannabis for non-medical purposes. Yet on college campuses, for us all to be compliant with drug-free schools and campus regulations, use, possession, public use remains illegal. So if the main harm someone's trying to avoid is, I don't want to get on trouble on campus, abstinence may be what they choose. If there are harms that the best way to reduce involves abstinence, they might choose that as well. But if people make the choice to use, any steps towards reduced risk, again, are steps in the right direction.
Yeah, that's spectacular. I love that take on how harm reduction, really focuses on just changing the way student athletes are thinking about their use. And sometimes that might end up with abstinence, but sometimes it just means eating more or drinking more water and therefore having a different outcome. So I love that. So
I'll just add really quickly too, sorry. What's amazing is I think where the mixed message can come in, where people get nervous, is when they blatantly give a mixed message. I've heard presenters stand up in front of groups of students and say, look, I know you're all going to use. So if you do this. First, I know you're all going to use is a misperceived norm. They're not all going to use. Many don't. And if they are under 21 in the case of alcohol, if it's on campus in the case of cannabis, I know you're all going to use. So if you do this, that does sound like a mixed message. So we always remind people of the legal issues. We don't want to inadvertently feed into a misperceived norm. All of that becomes important as well.
Yeah, that's great. And it makes a lot of sense. So Tim, we heard Jason mention, and I know you're aware of this, that CSMAS's recommendation to remove cannabinoids was not ever meant to condone use, right? It aimed to focus on identifying student athletes with problematic cannabis use. So can you talk to us a little bit about how this shift in strategy aligns with science and evidence, and how can our member schools amplify this message?
So I'll just tell my own journey. So I came to UCLA in the late 90s. I joined the faculty in 2002. So 20 years ago, number one, we were not even talking about cannabis at all. We were very much saying, oh, we don't know anything about it. Don't even bother with it. And we were lumping it in with the same level of other very, very dangerous substances, cocaine, heroin, and treating everybody that. The whole emphasis by legalizing cannabis in California in 2016 was to elevate discussion to do exactly this, which was to minimize harm, increase discourse, and reduce confusion. So the way we're thinking about it now with our UCLA student athletes, that here's a substance that's meant to be 21 and over. Here's a substance that has been, for better or worse, normalized in terms of usage. But any other substance, we want to recognize there can be risk for some, but not all. The way I think about it now is it's kind of like a blood screening test. So if you get a CBC and you find out that you have elevated white blood count or you have anemia, you're at risk. So we're now thinking about that as screening as an early sign of detecting potential risky use based on what's in there, instead, again, of punishing people. Again, problematic use is very different than just regular use. I deal in the lane of folks with addictive disorders where it's clear their use of cannabis has created damage and harm to their bodies and to their lives. We've removed all that in the sense of saying, hey, here is a substance, and we want to educate you as an athlete, you as a student, you as a healthcare administrator about what does it mean to have cannabis on its campus. So some clear basic things we learned at UCLA over the last several years. Number one, we have to respect the Controlled Substance Act, number one. Number two, we're not condoning and endorsing cannabis use in any way. It's not like we're saying to recruits, hey, you come to your locker, you're going to get a package of CBD and THC gummies for you. No, we're not removing the risk and harm and allowing folks to go onto the practice field intoxicated or go onto games intoxicated. The way we pick up, quote, problematic, risky use is the same way we pick up any sort of issue with mental health or addiction-related problems for our student athletes. Maybe there's an issue, a performance issue. Maybe they show up late. Maybe their grades are suffering. Maybe their athletic performance is struggling. Or maybe the athlete themselves is just saying, I can't sleep. I'm in pain. I'm depressed. I'm not feeling great. Those are our early signals of saying, let's get you in front of a health professional and determine what's going on. Our now urine drug screening is now being used not to detect people and catch people, but it's being used to detect anyone who's using cannabis. And then we're going to have a conversation that has no punishment attached to find out, how are you using cannabis? Is this helping you? Is this hurting you? Is there a mental health issue underneath? To pile all of that together, again, is a massive shift in the conversation tone. When I first started working with athletes about 10 years ago, it was very much, let's find out who's using them, let's punish them, let's suspend them, let's take their scholarship away. I can't tell you how much of a massive sea change that is. And for a lot of the administrators listening to this for the first time, they're like, well, yeah, but shouldn't we still be doing that? One of our challenges is no, we shouldn't just be punishing people for using, but we should be using our tools and resources to identify athletes who are using in risky ways, who have untreated mental health conditions. That's what we should be focusing on.
I love that, Tim. And it reminds me of my favorite story that I tell when I talk about the process of removing cannabis from the NCAA banned substance list and this shift towards harm reduction strategies. And that is, in the 15 years that I was a team physician on campus, part of my role was if an athlete tested positive, they'd have to meet with the team physician, right, to talk about what the next steps look like. And during those conversations, I would ask the athlete to tell me about your use and tell me about, and without fail, 99% of the athletes that I counseled, they actually denied ever having used the substance, right? So, Doc, I don't know how that substance got in my body. I promise you, I have never used. I don't even hang out with people that use, right? And it's very difficult as a physician to start to have conversations with athletes about their patterns of use if they're not willing to admit it. The minute the NCAA removed cannabis from the banned substance list, immediately those conversations changed from I've never used, that must be a mistake, to I've used every day since I was 14, or I use on Saturday nights after the game as a way to celebrate or relax or unwind, or cannabis really helps me sleep, so I use it when I need a good night's sleep. And then it allowed for this space to have this conversation between a patient and their doctor. And to me, that's probably been the most profound thing that I have seen since this change was made. So follow-up question for you, Tim. You mentioned screening in your last answer. Since the NCAA no longer tests for cannabinoids, can you talk about the role of campus level screening and testing and what, how does that help identify problematic cannabis use as it pertains to this overall harm reduction strategy?
So just this year, 2024, and we're coming to you live in fall of 2024, so people know where we're at. Here's the things we've done at UCLA. So we still do our 4 times a year random urine drug testing of our student athletes. We have 700 student athletes. We'll randomly get to about 300 of those athletes in 1 year. Our THC screener inside the urine drug panel is embedded. You can't take it out. So that means we're going to be screening for 10 different substances. We've now made a determination that any athlete that tests over 150 nanograms per ml on those random urine drug screens will have a mandated conversation with one of our addiction psychiatry team members. It's not the team doc, it's with a doctor like myself. Not a punishment, it's a conversation. And we framed it to the athletes saying, it's no different than if we found something on chest x-ray or physical exam. We want to have a discussion for you about what this level means. For anyone under 150, from 0 to 150 nanograms per ml on the random urine drug screen, we're giving them an option. You say, hey, we know that there's some cannabis in your system. Would you like to learn more? Would you like to talk to an expert about what this means and what the implications are? And then that's it. So that's what we do with urine drug screening. No punishment, no removal. And that was a key thing. The second thing we did at the beginning of the year at all our PPEs, we encourage our athletes to inform them. We've given them a handout that says, here are the new NCAA rules. Here are our UCLA rules. Here are just some facts to make sure the athletes know that, hey, it's still illegal federally to use in your dorm room. It's still illegal to use if you're 19 years old on campus, and you're still going to have tested in UCLA. The other thing we've started doing is what we call cannabis conversations, and you just use that exact word. So at the beginning of the year, we've had some team had said, hey, we'd love to have a cannabis conversation. So they've given us, like myself and some of our other psychologists and psychiatrists, just 10 or 15 minutes. We're being able to go in front of the team and say, hey, this is the new rules from the NCAA. Here's what we're doing at UCLA. And here's where you can go to get information about cannabis. So we've been able to refer our student athletes to SSI products, things that are on the NCAA website, our UCLA cannabis website, trusted places where they can get information about cannabis and health and wellness. We don't want any student athletes just going down a TikTok rabbit hole to find out stuff about cannabis. We want them going to trusted sources. Combine that all together. So we're still screening, but we're having conversations. We're giving athletes education. We have no agenda here. And that's really led to an area where our administration feels good about where we're going. It used to be, again, and Jason's similar, I'm sure, where we'd get those questions 3-4 years ago. What are you doing about this athlete? Why is he or she still testing positive? Your program is not being effective to get them off cannabis. But we would say, but they're functioning incredibly well as a student. There's no element of addiction. So, we're missing the boat here. Anyway, so that's what we're doing at UCLA for screening, education, and making sure athletes understand with full transparency what's happening here. And again, no endorsement. No one is running around with a CBD or THC sponsor on their uniform. And again, there's no THC being given out at the university level.
Or if I had, Dina, you asked about upper campus, like what's happening in campus in general. So our state legalized in December 2012, and in spring 2013, I moderated a webinar as the chair of our College Coalition on Substance Misuse, Advocacy, and Prevention with Dr. Wayne Hall from the University of Queensland in Australia. A lot of people think, including me, that Dr. Hall is like the biggest cannabis expert on planet Earth. And I asked him, after cannabis legalization, if we could do one thing in our state, what would you recommend? And his answer surprised me. He said, over 10 years ago, he said I would screen on campus in your health and counseling centers for cannabis use, and particularly cannabis use disorder, being addicted. Not expecting that answer, I said, what leads to that recommendation? He said, we don't know what comes first. We don't know what drives what, but we see a scary three-way relationship between cannabis use disorder, depression, and suicide risk that is so strong that if a student willing to say, I'm looking for help for my depression, also flags as cannabis dependent, that person poses a suicide risk that we cannot explain. He said, if you have a waiting list, don't put them on the wait list. They become number one priority for an assignment to a provider. Ever since he said that, I have looked at our country's National Survey on Drug Use and Health data. This is not causal, but people 18 and older in the United States with a past year cannabis use disorder, 18% also report serious thoughts of suicide. People 18 and older with no past year substance use disorder, that number is 3.3%. Both are upsetting. We want to look out for, and we root for people to have a happy, healthy college career. Yet rates of serious thoughts of suicide are 6 times greater among people with a cannabis use disorder in the past year. Making a suicide plan is 7.5 times greater. Attempting suicide is over 8 times greater. 2.5% for people with a past year cannabis use disorder, 0.3 for people without. So I always think of Lori Davidson in her work with the Suicide Prevention Resource Center said, if you want to be a campus that does good suicide prevention, do good alcohol prevention, because alcohol prevention is suicide prevention. I heard her say that. I said, I love that quote. Can I quote you on that? She said, yes, and I don't think we're that far off making the same claim about cannabis. Clearly what we do to identify students who may be struggling with cannabis use, even at the level of a cannabis use disorder, will likely pay dividends around mental health concerns when we can address that as well.
Thank you so much for that. I can't tell you how important that message is to get across to campuses. I have heard so much from campuses saying, well, now that the NCAA isn't testing for this, it's not on the banned substance list, we don't see any reason why we should test or screen for it either, right? And so that message is part of the message that I am trying to get across, that there is still significant value in testing. And when I say or screening. And when I say screening, and this is what I tell campuses, I don't necessarily mean that it has to be testing, right? There's other ways to screen. And so, Jason, can you talk to us a little bit about some validated screening tools that can be used to help identify student athletes who might be experiencing problematic cannabis use that maybe doesn't include actually testing for the substance?
Absolutely. And certainly, this is an ever-changing area of assessment because our terminology has changed so much. 10 years ago, some of the best measures out there would ask, do you smoke marijuana? And someone who uses daily edibles could say, nope, and they're not lying. They answered your question honestly, yet we've missed their daily cannabis use. The other thing that's happened is, in our state, we've passed legislation that when we talk about cannabis at the state level, that's the term we use. We have learned that not all college students use that term. I worked in a student life office for years where we would ask people, have you used cannabis in any form in the past 6 months? And students would say no. And with nothing to hide, when they met with one of us, they'd say that they use weed every day. And we're like, hold up, you said you don't use cannabis. They're like, I don't know what that is, but I use weed. It's right here. Nothing to hide. So it could be as simple as being mindful of your verb choice, not saying, do you smoke? Do you vape? Asking, have you used cannabis? Do you use cannabis? A student that doesn't will say no. If a student says yes, you can ask, what does your cannabis use look like? How often do you use? Anything that keeps it open-ended, casts a wide net. If you use the term cannabis, define it. We define standard drinks. It's harder to define standard dose, but to be able to say, I'm going to ask you questions about cannabis. And when I say cannabis, I mean fill in every blank you think the student might use. From a validated standpoint, we're big fans of the Cannabis Use Disorder Identification Test, the QDIT-R, the QDIT Revised. That is in at least in Washington State, the Washington Recovery Helpline even got that out there and made it available for providers. That was also when Dr. Hall made his recommendation that we screen, that was what he recommended. Is
that resource a free resource for campuses, or do they have to pay for it?
No, it is free. It's in the fine print in the publication. The authors say, please cite this if you're using it. And that was a long time ago. I know that I can make sure. I assume there's a way to embed links in this webinar, but I can make sure that in the description, the Washington Recovery Helpline got it out there. They got permission to put it out there for providers to use. Certainly, that website is accessible outside of state lines. And so it's a simple 8-item question. It starts with this: a yes, no, have you used cannabis in the past 6 months? If no, you're done. If yes, there's 8 items. And there's very clear guidance on how to screen it. And there's very clear guidance on how to interpret it. And we would never diagnose someone from an 8-item survey. But it starts a conversation. I love what Tim's saying about the conversation. It's all about the conversation. I love the way that it's focused on how are you doing as a student and not about punishment. And that's exactly what this is all about.
Yeah, that's spectacular. And I do have a follow-up question about these sort of survey-based screening tools. If a school were to choose such a tool, how do you go about promoting like trust and honesty in the responses from student athletes when, they may worry about, being honest on these types of things?
Validity and reliability of self-report can be enhanced when you let people know that it's confidential. So it's obviously not anonymous if I'm talking to you, but if I can with a straight face say this is confidential, that matters. If you allow people to skip items that they don't feel comfortable answering, that's okay. But more than anything, when you do have reliable and valid measures, when you don't create something that might have some loopholes or area of confusion or things like that. I have seen, Dr. Hall's recommendation is that campuses screen in counseling centers, in health centers. Certainly, we're talking about the opportunity to screen among trainers or anyone providing healthcare in an intercollegiate athletic setting. I've seen schools be really creative. I don't know that I should say the school in case they didn't want to be outed, but I got an email from a school this week that they put QR codes up on shuttle stops and bus stops, wondering about your cannabis use. They do the QR code, it brings up the Q to R, that very measure I just referenced. They take it out, they can answer the 8 questions on their phone, and it lets them know you may be at risk for some of these things. Their utilization data are stunning. It's one of those if we build it, will they come kind of issues. They're showing up and they are taking these surveys, and they're all anonymous. And so it's purely how many students have actually followed this QR code. I know of at least 2 campuses doing that, and they are broadening the ways in which students can learn more about the potential impact of their cannabis use.
I think from a healthcare standpoint, number one, it starts with leadership. So when your athletic director supports this, it's going to happen. When you do your administration, your school administration happens, it's going to happen. And I think when you tie it into mental health, that's how it does. So again, at UCLA, what we do a PHQ-9 at the beginning of the season and also throughout the season. And then if that indicates some mental health distress, then you go on to do some other additional screenings. But when I do trainings of team physicians and trainers, I'll say, you know what, this is really where I'm worried about most. I'm worried about when students and student athletes are using daily, when they're using high concentrated products, and when they started using cannabis at a younger age, like 16, 17. So you start to say, well, wait a minute, how do I find those? That's really just, again, having those conversations with your athletes and endorsing and creating a culture to say, hey, please fill out these forms because they are super critical to maintain your health and wellness. We are not trying to catch you doing something wrong. And I think that's so clear that athletic trainers need to do that. I've seen a lot of times when they'll be like, oh, just fill this out because the docs tell us to do it. That's not putting an importance on it, right? Or the athletes are like, doc, I don't want to fill it out because I don't want what? My coach to find out. So when you have a consolidated effort, athletic director, coaches, trainers, school administrators that start at the beginning of the year, and as an example, I think for lower resource schools, if you can't meet with everybody, make a short video. Make a short video that you can distribute out to all the teams to say the importance of, hey, here's where we are in cannabis this year. Here are our campus resources. Here's what's going to happen. Here's what's not going to happen. We've already seen the change this year where a lot of athletes now are actually coming out and saying, hey, I'm curious to talk to you about cannabis, knowing full well they're not going to get into any trouble if they admit. I think that's exactly where we're at. And so that's why those screening questionnaires are useful, but only useful when you explain to the athlete and the student and to the trainers their various other purposes. Otherwise, they're just, going to be more and more data that get thrown in the electronic record.
Yeah, that makes a lot of sense. When we think about how to go about administering these types of screens, even the simple survey-based ones, a lot of responsibilities fall on our athletic trainers on campus, right? They're always the group that's being asked to do the extra work. And so are there other people on campus that could be involved with this screening process that, could maybe spread the wealth a little bit?
Absolutely. I mean, as you heard me say, counseling center settings, health center settings, health promotion, health and wellness offices do this as well. And you heard me say there are even campuses that have put it out there for people curious about their own use. I think I loved what Tim said about the opportunity for conversations. I think students are hungry for this content. I almost hate bringing up the pandemic, but keep in mind that where you typically learn a lot about alcohol and other drug uses, high school health classes, the people who are ninth graders, when schools went virtual, a lot of that AOD content and education went away because it was like that core educational content. So I've had groups of students I've presented to where you can hear a pin drop and I'm kind of like, what's going on? It's because they haven't heard any of this stuff. So I really do think that there are students genuinely hungry for this. And we've learned more about cannabis in the last 5 years than we have in the previous 50. So I think that the fact that we have really good research to get out there now means these conversations can be really cool.
Jason, I appreciate you bringing up the health promotion departments on campuses because I personally believe this is an underutilized connection on athletic departments, right? Most campuses have health promotion departments that are doing this work for general students. And so we don't have to recreate the wheel here, right? We as athletic departments can partner with our local health promotion departments on campus to really say, okay, what are you all doing in this space? And how can we make sure that your communications are being targeted to the student athlete population? So I appreciate that. Tim, sorry, I didn't mean to cut you off.
Yeah, of course.
I want to make that a commercial, what you just said, Dina.
Okay.
That was amazing.
Let's do it.
Yeah. One of the cool things we have at UCLA is a program called Student Athlete Mentors. So it's student athletes themselves, who are the upperclassmen, who meet with other athletes in just peer groups, and they talk about these very issues. So we've now partnered with some of the student athlete mentors to give them some training on, train the trainer, give them information on cannabis, and they themselves run it. We also have a class at UCLA in undergrad class from pharmacology to public policy on cannabis. So it's a class, it's an actual undergrad class. But the power of student athletes taking the mantle on this from themselves, I think, is just not done nearly enough. So the idea that they themselves are teaching themselves, they get a little bit of training from, an old faculty guy like myself, and then they're teaching each other. That's what's really nice. And again, and we always hear about the quote lower resource schools. How do I do this? Every school can do this on the cheap. Empower your student athletes to get the right information and to teach each other. I think that's incredibly valuable. Absolutely, moving forward.
I completely agree with you, Tim. And I think that I hear this theme over and over from student athletes, like no offense, but we don't want to hear somebody stand up as an expert and talk to us about X, Y, and Z. We want to hear from other student athletes, and we want to hear from people that we can relate to. And so I think that is, a really important aspect here. I want to transition a little bit into the conversation around connecting athletes to care. And so, Jason, recognizing cannabis use disorder as a mental health condition, how can the management of problematic cannabis use and/or cannabis use disorder be incorporated into existing mental health action plans? We don't have to create whole new other plans here. How can we talk about kind of weaving that in?
Great question. And I think, we talk a lot about screening, brief intervention, and referral to treatment, and expert services, if you will. And there are some students that may need more than just kind of check-ins if they're really having a tough time. I could talk about this forever and I will not. I think the two things is that I would say is your point about recognizing it as a issue that's worthy of support, counseling, follow-up, and so on. I think we need to legitimize that. I think we can do better, making sure that people understand that cannabis is addictive. We hear far too many people say, well, weed's not addictive. It really is. And it's not helping anyone who's struggling by insisting that it's not. The other thing that we've really tried to do is put a spotlight on what withdrawal looks like. I mean, there is withdrawal from cannabis, and it usually could be a sign that someone is having a tough time with cannabis use disorder. Withdrawal symptoms include depressed mood, anxiety, difficulties with sleep, reduced appetite, headaches. And I think why that's so important is you might hear a student athlete say, well, weed helps my anxiety because whenever I don't use, I get anxious. And when I use, my anxiety goes away. That's withdrawal, and that's managing withdrawal. And so, there's an entire area of psychology, of mental health, of addictive behaviors referring to relapse prevention. If someone sets a goal, how do you work toward them both meeting that goal and reduce the likelihood of a slip, a lapse, or in quotes, a relapse? And so if someone says, I use when I'm anxious, and now I'm going to try not to use, how are they going to cope with anxiety? It's looking at those coping strategies. I think it's making sure that people know that there are support services for things like that on or near campus that they feel that they can access.
Yeah, I appreciate that.
So let me
yeah.
add to that. There's a couple of things there. Number one, it starts with think about your campus and what you have there as treatment providers. Now, many folks have, student health centers that are completely overrun and overmatched, and not every campus can have addiction experts like myself and Jason. So your own campus, you have to strengthen your knowledge and skills of your own providers. And a lot of college mental health providers don't feel nearly as equipped to deal with addiction. So you have to invest in your local providers to get more training. That means they can go to addiction conferences, they can get addiction supervision. The beautiful thing about what we have now with telehealth is that no matter where you are, you can probably get partnerships with telehealth providers who are experts in addiction and mental health. So I think a lot of campuses have to do that. From the student perspective, there's 3 lanes of engagement. There's health and wellness, there's treating a diagnosable condition, and then there's sport performance. And I think sometimes we don't cross those lanes over enough, where a lot of the folks who work in mental health performance don't recognize that, again, cannabis can have tremendous impacts on sport performance. So with a lot of our athletes, to give you an example, we had an athlete this week who he's been injured and he hasn't played all year, and he's been doing his recovery in the weight rooms and a little bit off the time. But the trainer noticed that he was isolated, he looked grumpy, wasn't talking, and wasn't eating with his other teammates at lunch. So the trainer recognized, hey, there's a concern. I don't know what's going on, but I'm worried. She approaches the athlete and says, hey, I'm worried about you. I want you to see the mental health team. He said, no way, I'm not doing that. Forget it. I'm fine. Leave me the F alone. Pardon my French, right? Familiar story, right? The trainer then goes to the team doc and said, I'm really concerned about him because he's not the way he normally is. I don't know what's going on. The team doc then says, I'm mandating that you see the mental health provider because we don't know what's going on. Just go. They mandated it. He came in, we talked, and immediately we identified cannabis use disorder, major depressive disorder, and he was using daily high concentrated cannabis vapes that were about 70-80% that had just started about 8 weeks ago. That was explaining his mental health. That's how you get care. So you have to have a combination of voluntary access when they want to go, but a firm procedure when there's clear data and evidence by the athletic trainer, team, or anybody that something's going on. You can't just let it go and say, you know what, let's not do this. So I feel really strongly when the power of the athletic trainer feels like they can trust and get their information to the team doc, who can then mandate that has to happen. So all of this is done without the coach's involvement. And I think that's super important when you think about how do you engage some folks into care. Sometimes they just have to go. No one wants to go see the doc when you have a lump, in your throat, right? Or they run, but no one wants to see the doc if they have a mental health issue, unless, that's a perfect example of how we get folks into care.
Jason, anything to add to that?
I think it's a good summary.
Good. Yeah, no, I think it's important because I think when we think about any of these diagnosable conditions, we have to think about there being more than one way to access care, right? Sometimes it's the athlete saying, I need help, where do I go? Right? It's not always that simple. Sometimes it is the athletic trainer or the team physician recognizing, hey, I think this person needs care, right? And then sometimes it's a full-blown emergency, right? Where something has to happen and it has to happen now. And I think that as we talk about mental health action plans and we talk about emergency action plans, and as we talk about weaving substance misuse into that, we really talk about campuses needing to make sure that they know what their mental health emergency action plans are. They know where substance misuse fits into that equation, and that they ask those questions and that they practice it and that they rehearse it. I mean, this is part of the new mental health best practices. So I love the way we're sort of tying this all together. I wanted to ask a question about under-resourced schools. And, Tim, you mentioned multiple times in your answers today that it doesn't take an A5 school with, multi-million-dollar budgets to put these things into effect. So can you just talk for one more second about ways that under-resourced schools might be able to put together sort of basic programs for this type of support?
Yeah, and again, I think looking at using telehealth and partnering with folks that might not be necessarily on their campus, but provide that expertise, and utilizing their insurance plan or other things like that. Even things like online webinars. For example, any school in America, if they wanted to have folks like Jason or myself come in and do trainings remotely like this, we can do that. And we can do that, at no cost, or, and provide those services there. Schools can also compile a lot of these great online resources that have a very nice packet of updated information that's easily distributed. When I talk to some of these other smaller schools, they always say, we just don't have enough providers. And we have long wait lists. And I think it goes back to the administration saying, where are you going to invest if you have to invest in having access to care and equity to care? That's an example of how you do that. And again, it can't say it enough. Having students leading the charge themselves. When the students empower themselves, maybe they get, extra credit for school, or maybe they can do a research credit class to beef up some of these support systems for themselves. Even podcasts. These are things that we're starting to see in other areas where when you have school-run podcasts that are very, very, don't cost anything, but they get the information out to students and to trainers on a very, very simple level. So all of these don't cost a lot. I think a lot of times schools feel like, we have to spend money to hire someone to come into the team or into the athletic department to do a special service, when you don't always have to happen. Again, the NCAA has a lot of stuff. SSI Institute has tons of stuff. Jason's shop has a lot of stuff. Our UCLA stuff has a lot of information out there. So again, the telehealth barriers are removed. As an example, anyone in the state of California, they can be seen by our UCLA clinics. You do not have to be in LA only. And we accept Medicare. We take certain forms of Medi-Cal. We take most insurances. So the idea that experts don't have to be physically on your campus, they can be within reach, even in not only in your state, but nationally.
I would add, I love that statement. In the alcohol field, one of the best tools we have for reviewing empirically supported approaches is the National Institute on Alcohol Abuse and Alcoholism, NIAAA's College Alcohol Intervention Matrix, College AIM. They rate over 60 individually and environmentally focused strategies around prevention and intervention to impact drinking. And yet my favorite sentence in the whole thing is that a mix of strategies is best. I think that has to be true here too. If a school says we do nothing but policy enforcement, you're missing education. If a school does a lot of education, but they're not doing prevention or intervention, you're missing that. You need policies, enforcement of those policies, education, prevention, intervention, treatment, and recovery support. How people get that prevention needs to be a mix, though, as well, too. We know a lot more about alcohol prevention than we do about cannabis prevention, the published literature. And peers can be an important part of a prevention puzzle. They can't be the solution. There's some research that looks at the potential effectiveness of peers, and there's some groups of students who say, well, I don't know if that person's judging me as a classmate. I don't know if they're as credible from what they're sharing with the science that they have. Peers can be unbelievably influential in many domains, but a school that says we're going to outsource all of our prevention to our peer health educators, that can't be the answer either. I have a colleague in this field that I think so highly of that at a conference recently says, don't deputize your peer health educators as health educators on campus, like health professional staff, because they can be a part of the puzzle. They can't be the sole solution. I think that's important to keep in mind too.
Yeah, that's really spectacular. I appreciate that insight. So as we wrap up here, I want to give you both an opportunity for any closing comments. If there's any areas that you would like to touch on or talk about before we wrap up, now's the time to do that.
This is great. And I'd love to watch this video again 5 years from now in 2029, when I have a full head of hair again and whatever. But the point is, we're in the kind of first quarter of this. And I think, number one, cannabis use disorder addiction looks funny in the sense that it's hard to visualize. We do have some effective psychotherapy treatments, and we don't have a lot of great medication. We have some. But I think it's important for folks to recognize health and wellness conversations first, recognizing that the cannabis available to all of us to consume is very different than the cannabis from the 70s and 80s and 90s. And that if I had a strong prevention message, it's not to use daily, it's not to use high concentrated products, it's not to use by yourself. We also know with pretty clear definitions right now that cannabis does not improve athletic performance. We know that cannabis as a medicine, medical use of cannabis for mental health doesn't work. Cannabis for other parts of medical conditions is debatable, but it's not that great of a medicine. So for oftentimes, there's still some mythology about cannabis. Oh, it's great for recovery, it's great for pain, it's great for, sleep. And the data is that's not great like that as a medication. So in summary, again, it's about, think about your own school. Think about what you have. And I love what Jason said is add more. If you don't have prevention, add more prevention. If you don't have treatment experts, find some who will train up your current roster of folks. If you have athletic trainers, get them time and space to learn about this information, because they're the ones that are really serving as that go-between. Again, for people who want more information, I'm available. I'm available to do trainings by Zoom or in person, guidance and supervision for clinical support, or anyone who has clinical cases that they need guidance on. And again, we're constantly evolving our policies at UCLA all the time there as well. And I'll leave an open shout out for anyone who wants to visit us at UCLA to look at our gorgeous now Big Ten Conference campus. We're available, and you can visit our lab at our UCLA Center for Cannabis and Cannabinoids, and we can talk about sports and mental health and cannabis and all those wonderful things. So thank you for your time, Dina and Jason. And Jason, the Zoom is yours.
I will take the Zoom and tag over. Thank you. I'll thank everyone for the participation and watching this. I hope it was value added. I would say three things. Fully acknowledging, I would fear the person that claims they have all the answers. That is definitely not me. We just heard Tim making a very important statement about cannabis and mental health. It's not helping for the reasons people might report that they want to see a benefit with. And I'll go back to what I said about withdrawal. If people notice when I stop, I get anxious, I get depressed, it must be helping my anxiety or depression. That's withdrawal. And so really making sure people can kind of look at, can I take a day off? Can I take 2 days off? If those symptoms emerge, that's noteworthy. Withdrawal is not forever. It will hit a peak within 3 to 7 days and usually be a non-issue within 3 weeks. But that might be a tough 3 to 7 day window. It might be a tough 3-week window. And it's making sure people know what to expect and have strategies to cope with that. The other piece are the harm reduction guidelines. It wasn't until January 2022 that we got published guidelines on lower risk use. The good news is they're out there in the scientific literature. The less good news is, how do we get them off the pages of journals and in people's hands? They include things like using low potency products where possible, using at a lower frequency. They define lower risk use as a day or two a week, weekend only. If someone says I use every other day from a frequency standpoint, that's pretty high risk use. They acknowledge that there's no one safe route of administration, but that said, smoking is without question the most unhealthy. So if people insist on using, it's being mindful of method of use. There is no substance more associated with causing attention decreases, let alone worsening existing ones, than cannabis use. So if people are noticing impaired memory, concentration, attention, stopping their use. And if stopping is not realistic to them, substantially reducing frequency and potency. I live in a state in which drugged driving deaths outnumber drunk driving deaths. That's hard to say. That's sad. people get don't drink and drive. But when people say, well, it's cool, I drive better when I'm high, they really don't. Harm reduction guidelines include waiting at least 6 to 8 hours before you even think of driving. If it's been smoked, vaped, or inhaled, 8 to 12 hours if orally ingested. I think we can do a lot more to get those harm reduction guidelines out there. And lastly, at the end of the day, there's students on our campuses, and especially post-pandemic, we heard upper-level administrators say, I want to be the biggest champion ever for graduation rates, for retention, for student success. We can all get behind that. That also means be a champion for substance use prevention, because what you do about substance use on campus will pay dividends in the classroom. Literally, there's no substance more associated with decreasing attention, concentration, memory. When people who use every day stop, those attention, concentration, and memory decreases improve. They match that of people who don't use. The word of June in clinics in Seattle was disentangle. In this summer, we saw more people seeking a diagnosis of or prescription stimulants for what they thought was ADHD to a person they were using cannabis. Providers were telling people, you need to try and call timeout on your cannabis use for 30 days so we can disentangle, there's the word, what could be an underlying attention issue from the side effect of your substance use. So if students see thriving, flourishing academically, if they see challenges to that, because they're struggling with attention, they're struggling with concentration, they're struggling with memory, if they're using cannabis, that can be a causal relationship, and changes they make in their cannabis use will pay dividends in all of those abilities. We'll see that translate to success in the classroom. So I hope that wasn't too long a wrap up, but thanks for the chance to work with you. And Dina, I'll tag back over to you.
Well, Dr. Kilmer and Dr. Fong, I want to thank you both so much for your time and your willingness to be such great partners in this space. Your expertise and your passion around this issue is clear, and I think our membership is really lucky to be able to learn from you in this area. So I really appreciate everything that you guys have done for us. And I'd like to thank the audience for tuning in today. We hope you found this session helpful, and hopefully you gained a little insight into how harm reduction strategies can be implemented on your campuses. Please see your email for instructions on receiving your certificate of completion. And don't forget to reach out by emailing us at ssi@ncaa.org with questions or to suggest additional content. Thanks again, and I look forward to seeing you all at our next SSI Spotlight.